In this lecture, we begin looking at the function of the kidney and the nephron and the actions that have to occur as it goes through that process in order to produce urine and therefore regulate blood composition. So I've broken this topic down into several parts. As first, we'll look at an overview, and then we'll look at very specific portions of the nephron and the actions that go into producing urine and regulating homeostasis of the blood at those particular locations. So some of this part is going to be review, and some of this particular lecture is going to be setting up the other topics that we'll get to. So if you recall, we had blood flow going to the kidney, dividing up, traveling blood through the kidney, and ultimately bringing it to the nephron, beginning with our afferent arteriole. That was the artery that brought blood to the nephron so it could be filtered at the glomerulus. And ultimately, anything reabsorbed at our nephron and back into the blood was taken up by a combination of our peritubular capillaries and the vasa recta. We filter blood at the glomerulus to produce a tubular filtrate. Fluid, water, and any dissolved solutes are going to go through slits in the glomerular wall and enter the Bowman's capsule. From there, we'll make our way down the tubular portion of the nephron through our proximal convoluted tubule, down both limbs of our loop of Henle, into our distal convoluted tubule, down our collecting duct, and at this point here, just to reorient us with our anatomy, we will pass through our renal papilla and into the minor calyx of the collection system for the kidney itself. Anything that doesn't get reabsorbed at the glomerulus exits the glomerular capillary bed through the efferent arteriole. And from there, they will pass through a network of capillaries that surround the nephron tubule. That's our peritubular capillaries and our vasa recta. Anything reabsorbed from the nephron after it's been filtered and back into the blood is picked up by these capillaries surrounding the nephron tubule. Now remember, when we looked at the orientation of the Bowman's capsule, even though this is the way we see a lot of these diagrams oriented, really we see a rotation anatomically, as the distal convoluted tubule realistically sits right here in the V-shaped formed by our afferent and efferent arteriole. So it's like we have to take our Bowman's capsule and swing it around to orient itself towards the distal convoluted tubule. And in doing so, this is the orientation we get. Our distal convoluted tubule sitting in the V between our afferent arteriole and our efferent arteriole. This anatomical orientation becomes extremely important when we look at regulation of filtration rate. One of the ways we will talk about regulating filtration rate is through a process called tubular feedback, where basically we look at the concentration of some solutes in the distal convoluted tubule and use those regular amounts, or those relative amounts, to infer information about the filtration rate. We have our juxtaglomerular apparatus in that triangular space formed by the afferent and efferent arterioles and the distal convoluted tubule. The juxtaglomerular apparatus is made up of two portions: our macula densa, which is going to be sensory cells detecting composition of the filtrate in our distal convoluted tubule, and our juxtaglomerular cells, which produce renin, which, as you'll see once we talk about filtration, go on to affect blood pressure and ultimately secretion of hormones like ADH and aldosterone. As we look at the overall processes of forming urine, we really have three different processes working together. So what winds up in the urine is the sum of these three processes. We have the filtration that occurs at the glomerulus. This is where we take the water and we take the dissolved solutes out of the blood and put it into the tubular portion of our nephron. As we go down the nephron, we take that tubular fluid and we start reabsorbing what we might still need and put it back in the blood through our proximal convoluted tubule, through our peritubular capillaries and our vasa recta. As we continue down the tubule, now we enter our distal convoluted tubule and collecting duct, and here we can see varying degrees of tubular secretion. Solutes that we can put into the tubular fluid without having to have them initially filtered at the glomerulus. They can pass from the vasa recta and peritubular capillary into the tubular filtrate, kind of running in the opposite direction of any reabsorption. So reabsorption would be solutes going from the tubule and into the blood, whereas tubular secretion would be solutes going from the blood and into the tubule. At the proximal convoluted tubule, we see a great degree of solute reabsorption. In fact, that's where we see most reabsorption. Most of the solutes we filter at the glomerulus are immediately going to get reabsorbed across the wall of our proximal convoluted tubule. Anything that doesn't get reabsorbed makes its way through the loop of Henle. The loop of Henle, we're going to see a great deal of water and salts get reabsorbed. Anything that doesn't get reabsorbed there passes into our distal convoluted tubule. Now here we get hormonal control over what we can reabsorb. So you'll see hormones like ADH, aldosterone, and ANP acting on our distal convoluted tubule to reabsorb what's needed from the tubular filtrate. And of course, anything that doesn't get reabsorbed there passes into the collecting duct. Once we get past our collecting duct, what we've created is urine. And once we've gotten that far, we have passed the point of no return. So at the end of the collecting duct, as we exit that renal papilla and start going down the minor calyx, major calyx, renal pelvis, and ureter, that's when we have urine. And at that point, what has already been put into the urine at the end of the collecting duct is there to stay with no mechanism of reabsorption past that point. So we filter out our glomerulus, and every step along the way, proximal convoluted tubule, loop of Henle, distal convoluted tubule, collecting duct, we have various mechanisms that we'll get into to reabsorb solutes back out of that filtrate, to reabsorb water and put it back in the blood, with anything making it out the end of our collecting duct becoming urine. Here's a diagram illustrating the capillaries that surround the nephron. Remember, these are the capillaries, the peritubular capillary and the vasa recta, that'll be picking up anything getting reabsorbed from the nephron and bringing it back into the circulatory system. Now, how we determine what gets reabsorbed and what passes into the urine all depends on the mechanism of transport that we see along the different locations of our nephron. We filter at the glomerulus, we pass those filtrates into the proximal convoluted tubule, and we start to see active reabsorption. Now, any of this reabsorption that we're going to see involves protein carriers, and that's really the start of the key to understanding how we reabsorb just enough solute to reestablish blood composition. Anytime we're dealing with a protein transporter, we will always have to deal with a transport maximum rate. A maximum rate in which we can reabsorb these solutes or transport solutes across a membrane. We discussed those way back when we did our membrane transport section, especially when we compared simple diffusion to facilitated diffusion. We said that for simple diffusion, there was a relationship between the stronger the concentration gradient would always mean a higher rate of transport. As soon as we introduced these protein carriers, however, in facilitated diffusion, we saw that same relationship, but only up to a point, because any protein carrier has a maximum rate at which it could work. So now the rate limiting step wasn't the concentration gradient, it was the mechanism of the protein carrier itself. We use this phenomena to reset normal blood composition. So let's look at glucose. It's one of the solutes that we already know most about, we're most familiar with, and we're still familiar with times when we urinate out glucose in the case of people with diabetes mellitus. If you have normal blood glucose, you are going to filter that glucose at the glomerulus, but in the proximal convoluted tubule, you have enough transporters dedicated to glucose to reabsorb back all of those solutes in the given amount of time you have, because time becomes a factor. You filter at the glomerulus, and it's like we've just pushed start on a stopwatch. You've got time counting against you now. You've got so many protein carriers that can operate at a maximum rate, and you've only got so much time to reabsorb any solutes you still need. So in a normal blood sugar situation, you've got enough time for the protein carriers present to reabsorb 100% of the glucose that just got filtered, putting it back into the blood, reestablishing blood glucose levels, and as a result, no glucose makes it to the urine. And we singled out glucose, but we will have transporters for calcium, magnesium, phosphorus, any solute. We'll have a set of transporters dedicated to it with its own particular transport maximums, allowing the nephron to bring back varying degrees of each individual solute to put back into the blood exactly what should be there, no more, no less. Now, you'll see the term transport maximum get used a little differently for the kidney. We changed the term. You'll hear the term renal threshold. Basically, that's the amount of each solute that we have the capacity to reabsorb. So you have a renal threshold for glucose, you have a renal threshold for sodium, you have a renal threshold for calcium, and so on and so on and so on. And providing that you have a normal amount of any of those solutes, you will be below the renal threshold for those solutes, and you'll be able to reabsorb 100% of it, with none of it making its way to the urine. The problem arises is when we have elevated levels, because when we talked about what the kidney and the nephron does generally in our last lecture, we said that yes, it eliminates waste products, true waste products. In those cases, we have no mechanism, no transporters dedicated to those solutes. So once we filter them, they're going to be gone. But if we have excess glucose, we don't need to reabsorb it all. Our goal is to re-establish normal blood glucose. So the amount of glucose you would have in the blood at that point would exceed our renal threshold. There would be too much glucose present for the protein carriers to be able to handle in the amount of time that it's given to handle it. As a result, we still reabsorb just enough glucose to reestablish normal blood sugar levels, and anything above that winds up in the urine. There is an old TV show. I'll be honest with you, I've only ever seen one episode of I Love Lucy, and I've managed to turn it into an analogy for nephron function. Lucy had this one episode where she was working in a chocolate factory. And the chocolates are coming down a conveyor belt. And her job was to pick them up and put them in a box. Just like glucose could be coming down the nephron tubule here. And your nephron's job is to take that glucose and move it back into the blood. The protein carriers dealing with glucose have a certain maximum rate at which they could work. Lucy has a certain maximum rate at which she could pick the chocolates off of the conveyor belt and put them in a box. Well, if you've ever seen the episode, the conveyor belt speeds up, more chocolates start coming down the pipe, and they exceed her abilities. Just like if more glucose was coming down the pipe, it would exceed the renal threshold for glucose. So she's taking them, and you can see in this picture here, she's even stuffing them in her shirt to try and get them off the conveyor belt as soon as possible. But if you watch the skit, you'll see that chocolates start getting past her. This would be the equivalence of that glucose coming down the loop of Henle, down the collecting duct, and out into the urine. Whatever we don't have the capacity to reabsorb winds up in the urine. So I've seen one episode. I've managed to turn it into an analogy for nephron function. Maybe I should go watch a couple more episodes, and maybe I could get more analogies out of it. When we look at how much gets reabsorbed at a given moment, we have to look at the filtration rate, and that's where we're going to go in part 2. The rate at which we filter solutes at the glomerulus will go a long way to determining how many solutes are in the tubular portion of our nephron, and it's going to go a long way in determining if we're going to exceed the renal threshold for those particular solutes, dictating what winds up going in the urine. It's going to be important to realize that what pushes solutes and fluid across our glomerular wall is a filtration pressure. We talked about blood pressure pushing fluid across a capillary wall when we did Starling-Landis fluid shift. This is the pressure of the blood at the glomerulus. Now, we distinctly call it filtration pressure right now, because what you'll see once we get into this discussion is that the filtration pressure and the blood pressure has to be talked about in two separate contexts. Because what we're going to do is take the blood pressure and manipulate it locally so we can get stabilization of our filtration pressure. So now that we've seen the overview on how we produce urine, the combination of reabsorption from different parts of our nephron tubule, we're going to look at how we create that filtrate in the first place, controlling that glomerular filtration rate. After that, we're going to look at each part of the nephron, and we're going to look at the exact mechanism of transport that we'll see at each site. So we'll take it one step along the way. Part 2 will come back with our filtration.